At Vantive, our mission to extend lives and expand possibilities starts with the commitment to continuous learning. We are committed to partnering with the medical community to support vital organ therapy innovation grounded in clinical evidence and focused on improving patient outcomes. The recent publication on endotoxic septic shock centers on an evidence-based approach to address clinical challenges in critical care and beyond, as highlighted in our press release. Please visit our website, vantive.com, to learn more.
Hello, and welcome to the 2026 Congress edition of the Society of Critical Care Medicine podcast. I'm your host, Dr. Elizabeth Mack. And today I'm speaking with Drs. Scott Weiss, MD, FCCM, and Dr. Pierre Tissieres, MD, PhD, about the 2026 updates to the Surviving Sepsis Campaign International Guidelines for Management of Sepsis and Septic Shock in Children. The full article is available in Pediatric Critical Care Medicine or PCCMjournal.org and Intensive Care Medicine. Listeners can also access the guidelines at survivingsepsis.org. Dr. Weiss is Division Chief of Critical Care and Vice Chair of Research at Nemours Children's Hospital, Delaware, and Professor of Pediatrics and Pathology and Genomic Medicine at the Sidney Kimmel Medical College of Thomas Jefferson University. Dr. Tissieres is Professor of Pediatrics, Head of Pediatric ICU and Neonatal Medicine at Paris-Saclay University Hospitals, and Director of the Host Pathogen Interactions in Sepsis Group at Integrative Cell Biology Institute at the French National Research Institute, CNRS, and French Sepsis Institute in Paris, France. Welcome.
Thank you. It's a pleasure to be here.
Thank you. It's a real pleasure to be with you today.
Before we start, do you have any disclosures to report?
I have received some honorarium and travel support from Thermo Fisher Scientific.
I have some consulting fee from Thermo Fisher, Bayon, from Beatrice, from Sedana, as part of my regular job.
Wonderful. So, as we get started, especially for our trainees and junior folks, I always like to highlight the connections that we have within critical care. And I would love to hear a little bit about how this group first gathered. What have you worked on before together? Love to hear your thoughts.
So it's a long story. The 26 guidelines is the evolution, the update of the 2020 guidelines. And at that time, with Scott Tex-Kissoon, as well as Mark Peters, we gathered a group of experts from every countries, from Europe, from the US, also elsewhere, with professionals from different disciplines and the pharmacists, so everybody that is working in the ICU. And we found a way to group all those experts together to build up the first 20 guidelines. And the 26 is just the evolution or the maturation, I would say, from the previous ones.
Yeah, I'll just add that it was very important that we had a diversity of opinions across disciplines as well as regions, noting that there are practice differences. And we wanted to make sure that the guidelines would be as universally applicable across all settings, healthcare environments, resource limitations, and so on. So we had to have a panel that was representative of all those areas.
Wonderful. And it really looks like you all enjoyed working on it, as best I can tell from your presentation today at Congress. So give us the skinny. What are the main changes that critical care professionals should be expecting?
So some key differences are that there were updates to areas about screening for sepsis and early recognition, highlighting that the field has evolved a little bit in terms of what people are doing to recognize sepsis early in their healthcare setting. And now more recent studies suggesting that are not clearly demonstrating that screening tools are always helpful in all settings. And so we need to better understand how do we utilize those screening tools in the current state of increased emphasis on early recognition of sepsis. Another area that was new to the guidelines was the use of supplemental oxygen. We have new high quality data that help to drive a recommendation about limiting hyperoxia and utilizing more conservative oxygenation targets in order to safely provide that therapy to children with septic shock. We also asked new PICO questions regarding immune dysregulation, and unfortunately weren't able to provide many recommendations in those areas, but simply incorporating and highlighting the importance of that we're hopeful will stimulate new opportunities for research in the future. And then last, for the first time, we addressed issues of post-sepsis morbidity and opportunities for optimizing long-term follow-up and risk assessment for children who survive sepsis, who have the potential to go on to have neurobehavioral and neurocognitive problems even after they leave the hospital.
I will add also that there is, in comparison to the 2020 guidelines, is that some aspects were already present in those guidelines, where reinforced, for example, lactate measurements, continuous reassessment, role of point of care ultrasounds and monitoring that were presented in the 2020 guidelines, but now are not considered as stronger objectives.
Wonderful. Thank you so much. I know that the critical care community will look forward to diving in. How do your proposed approach and definitions differ from the original Goldstein criteria and the later modifications that followed? And why do you think those changes were necessary for this iteration?
It's a very good question. Actually, we started in the 2020 guidelines discussing which are the topics of sepsis, because it's mostly difficult. And now we found out that we have a very practical approach to the definition, saying that sepsis is an infection with organ dysfunction and septic shock is the same, plus a cardiovascular failure. What is new in this iteration is that we have the possible sepsis, which is a condition where you consider the patient has sepsis, but you don't have the microbiologic demonstration, but you need to start treating the patient. So it's very practical. It's very helpful for the clinicians and for the young fellow to know that even though they don't have the definitive diagnosis, they can consider that this is sepsis and they need to start working on it.
I'll add that we were grateful to have the updated 2024 Phoenix conceptualization of sepsis that aligned the pediatric concept of sepsis with the adult sepsis 3 framework. And so that allowed us to standardize the language, not only within the pediatric guidelines, but across the pediatric and adult guidelines, which I think will be helpful to reduce confusion about the patients for whom these guidelines are most applicable.
Thank you so much. How does the group think about the balance between early identification, overdiagnosis, overtreatment, particularly in children with high baseline inflammatory states, like many of our chronically critically ill children?
What Scott just said before is that one of the major innovation of the guidelines is the importance of the early identification of the patient. And that's true that we move away from a systematic screening. So at some point, I think it's a major evolution of those guidelines.
Yeah, so I think, a lot of the guidelines, a lot of the recommendation statements have shown evolution from more is more to a more targeted, limited approach where we're not falling into a pattern of over-treating unintentionally. And at Congress this morning, Dr. Ranjit provided a really nice overview of how the recommendations and guidelines have shifted over the last 2 decades to do targeted, limited approach and not necessarily try to normalize all parameters, but rather take a multimodal approach to assessment and a more careful, titrated manner. And a lot of the recommendations reflect that global change over the last 2 decades.
Thank you so much. I'm curious, as we think about sort of the dissemination and implementation of this iteration of the guidelines, what do you think that looks like, or how do you think that looks different at 2 a.m. in a busy ICU when maybe the medical director is not around? How might that look different for our teams?
I think we were very sensitive to that important point because that's the situation where the guidelines, I think, can be most helpful. Those are people who may not live and breathe the guidelines every day, but occasionally come into a situation where they need that information and they need it right away. So in this iteration, we provided a more helpful figure that brings together most of the recommendations into one bite-sized piece that hopefully can provide people the information they need at a glance without having to comb through pages and pages of guidelines and rationale.
More practical approach to the implementation of the guidelines, I think.
How well do you think this framework performs in our chronically critically ill population, like our patients maybe with oncologic diagnoses or baseline organ dysfunction, maybe those who are tracheostomy ventilator dependent? Do you feel like this is really applicable across populations? And just curious your thoughts on that.
I think that the contextualization And the clinical contextualization for the application of the guidelines are really important. And part of it is the different types of patient, oncologic patient, chronic patient, immunosuppressed patient. At the end, the idea is really to bring up a canvas of guidelines that will help the clinician to apply standard procedures to take care and cure those patients.
Any potential unintended consequences in your view of widespread adoption, such as overtreatment, antibiotic overuse, alert fatigue? It sounds like you all are really thoughtful about the practical, tactical pieces of this, but just curious your perspective on that.
Yeah, I think it's important to point out that we utilize the GRADE methodology, which provides a framework for a rigorous assessment of the literature and only allows for conditional or strong recommendations if the evidence is there to make those recommendations. So in many cases, we were unable to the evidence was insufficient to issue a recommendation. That does not mean that some patients might still benefit from either giving or withholding that particular intervention. And so the guidelines should be sought to provide a framework for care that's applicable for most patients in most cases, but don't obviate the need for individualization and personalization. And so will work best when implemented in a thoughtful way for an individual patient.
All right. So let's dream for a minute. Let's just say we're here at Congress in 5 or 10 years talking about future guidelines. What is the next generation of pediatric sepsis guidelines, pediatric sepsis definitions look like? Do you think we'll be incorporating biomarkers, machine learning, continuous monitoring? I won't hold you to it, but would love to hear your thoughts.
For sure, better typing the patient might be very helpful in selecting the most appropriate therapy. But I think that one of the mainstream of those 26 guidelines is that we were able to identify some potential track of evolution of improvement through research. And what we saw, for example, from the 2020 guidelines is that it brought a lot of energy towards developing RCTs, trying to answer those questions. So I think that in the future, we will have more deep phenotyping of the patient, better identification of the patient. It should not be at the pace of complexity, but clearly it's also an opportunity to develop more advanced research and develop opportunities in caring those children.
Yes, I agree with Dr. Tissieres. And I think guidelines are very important to standardize care, but the aim of guidelines is to improve care for groups of patients. And when we are moving towards better subphenotyping, we'll eventually be able to personalize care and know which subgroups of patients should be treated differently than others. And then we can maximize the benefits for all patients as opposed to the average patient.
Thank you so much. Anything I've left out or you wanted to touch on that we didn't cover?
So for me, one of the other benefits of these guidelines is the novelty of bringing together clinicians and experts from all around the world under the SCCM and the SCCM umbrella. And for me, it was a real pleasure to find out new friends and work together and to develop very important document for the clinicians.
Yeah, I agree. The global community around this, it's a real rallying point for everybody to come together and bring things like this together. And, a lot of the work has stimulated ongoing research that with the next iteration will turn into new, stronger recommendations. There are ongoing studies around fluid management, blood pressure targets, use of corticosteroids, vasopressors, immune modulation, all of which are actively being conducted. And so the next round of the guidelines, I think, will have an even more robust evidence base because of, many of these studies are multi-centered, many are multinational, and that brings together a lot of people working together to improve the health for patients all around the world.
Well, thank you so much for your time today, and more importantly, for your work over the last 6 years and really combing through the evidence and trying to find, our North Star in terms of how we identify and manage these really important group of patients that we care for. I really appreciate it. This concludes another episode of the Society of Critical Care Medicine podcast. If you're listening on your favorite podcast app and like what you heard, consider rating and leaving a review. For the Society of Critical Care Medicine podcast, I'm Elizabeth Mack.
At Vantive, our mission to extend lives and expand possibilities starts with the commitment to continuous learning. We are committed to partnering with the medical community to support vital organ therapy innovation grounded in clinical evidence and focused on improving patient outcomes. The recent publication on endotoxic septic shock centers on an evidence-based approach to address clinical challenges in critical care and beyond as highlighted in our press release. Please visit our website, vantive.com, to learn more. Elizabeth H. Mack, MD, MS, FCCM, is a professor of pediatrics and chief of pediatric critical care at Medical University of South Carolina Children's Health in Charleston, South Carolina. Join or renew your membership with SCCM, the only multi-professional society dedicated exclusively to the advancement of critical care. Contact a customer service representative at 847-827-6888 or visit sccm.org/membership for more information. The SCCM podcast is the copyrighted material of the Society of Critical Care Medicine, and all rights are reserved. Find more episodes at sccm.org/podcast. This podcast is for educational purposes only. The material presented is intended to represent an approach, view, statement, or opinion of the presenter that may be helpful to others. The views and opinions expressed herein are those of the presenters and do not necessarily reflect the opinions or views of SCCM. SCCM does not recommend or endorse any specific test, physician, product, procedure, opinion, or other information that may be mentioned.